The next presenter is Dr. Raveendra T. He will speak on to create a guide for the correct disc sizes with varying biometric functions and a unified DDIS and CDR scale.
Good afternoon, sir. Good afternoon, madam. Thank you for the opportunity. No financial disclosures. Actually, we all know that glaucoma by definition is an optic neuropathy with typical alterations. And one of the most important factors with respect to glaucoma diagnosis is the need for generating the probabilities about the future with our human intelligence, that whether it is going to progress or not and what is the rate of progression. But here today we are focusing on the basics, like disc size is an important aspect, and CDR or inferior and superior rim ratios, which are both critical or sometimes very difficult assessments. As we see, we have got the disc damage likelihood scale, where we have got the disc sizes and the corresponding templates being given to us, but somehow we find that there is a need for further improvement in the disc templates, and that has been our effort, so that we can grade the discs as per the low risk, moderate risk or high risk at an early stage of the documentation. So here we are taking the 1 millimeter spot size, that is photographed alongside the disc, and whether it is equal to 1 millimeter or 1.6 millimeter. Like that, we will be making the use of nomograms for getting the actual value of the disc, and then after the disc size, whether the symmetry or asymmetry is there, and then whether the refractive status is on side of myopia or hypermetropia, so that the corrected disc size and the correct unified corrected DDLS CDR scale could be available for us. So here we find the difficulties with measuring the disc size being demonstrated. Most of the slit lamps don't have these facilities, and even if they are having a facility, it is not easily viewable, and therefore we came up with our own innovation and the templates using the 1 millimeter spot size of the slit lamps. So the relative size is seen, and then we are able to do the estimates. So here, whether the disc corrected size, actual estimated size based on the lens we are using, and the correction factor applied, these templates will be there, and we get the disc size. Once the disc size in millimeters is given to us, then we have to make the assessment related to asymmetry or symmetry. So earlier on, the templates that were given by the DDLS scale are present at disparate points, but here we have brought the numbers related to the risk very close to the templates. The template is having the grade of the DDLS mentioned here itself, very close to it, and the correction factor, whether it is because of the disc size or because of the myopia or hypermetropia, can then be calculated, can then be read up with the help of these templates. So if it is myopia, we go to a lower risk. If it is hypermetropia, we go to a higher risk. So we don't have to actually go for all the templates, but whichever is close and similar, that is what we will use. So here, if it is a myopia, if it is the small disc and this is the appearance, then we will read it as 4. and if it is large disk, we will read the score as 2. And if it is actually within the normal accepted range, like not more than 3 diopters myopia or 3 diopters hypermetropia, then we can take the scale as 3. And similarly, we can do the corrections with respect to hypermetropia and emmetropia, hypermetropia or myopia. But the key takeaway is that it is very important to be able to assess the disc size, and the tools that are available are very difficult to apply, and ultimately probably the machine learning tools and AI tools are required in this stage, in this area, and then we will be able to minimize the observer variations and improve the diagnostics, and then the treatment outcomes. Thank you.
Nice presentation. But what is how much is the clinical applicability of such tools?
Yes, sir. This is just in the concept stage, and clinical applicability is difficult. That is why the final stage is that slide is saying that we have to wait for the real automation with respect to this. We will be requiring the photograph and the parameters related to hypermetropia or myopia, those refractive status coming in.
Ultimately, any research has, we have to see the clinical applicability.
Yes. Yes.
So whether the this study will help in the clinical applicability, that's whether it can be used in routine OPDs.
Yes. Yes.
So I don't think with the variation and with the different tools needed for this, the availability and the applicability will be possible in the setup where we have the infrastructure set up in India.
The 1 millimeter spots slit lamp is available in most of the slit lamps. Okay. And in some of the JAI slit lamps it will be 0.5 or 2 millimeter. So the nomograms will be required for the slit lamp that we are having. The reference diagrams will have to be customized. So we have got the Topcon SL1E slit lamp where there is a 1 millimeter spot size. And in the JAI slit lamp we are having a 0.5 millimeter and then the 2. But in the Topcon SL1E slit lamp we have got the 1 millimeter spot size. And whenever the patient is having myopia, then we are finding that it is very small, this comparison in comparison to the disc appearance. Then we will say if it is 1.6 and the correction factor is 1.3 for the lens that we are using. So 1.6 into 1.3 and we get the correct size. So it becomes more than 2.8. And what the machine learning algorithms or AI algorithms will ultimately do is to read these things automatically.
So generally we use 90D or 70D for the examination. What is the correction factor in these two lenses?
In 90D we have got 1.4 for most of the models, and it is 1.1 for the 78D or 60D.
Okay, thank you very much.
Yeah.